Good afternoon, ladies and gentlemen. Welcome you for the Endocrine Symposium. My co-chair is Dr. Muditha Weerakkody, and our first speaker is Dr. Mona Gossmann from Cleveland Clinic, USA. Audio.
All right, thank you. So today I'll be speaking about some endocrine issues that are very prevalent in the elderly population. And I'm going to focus, this is a pretty wide topic. Today I'm going to focus mostly on diabetes and a little bit of thyroid, which tends to be the most common issues that general internists will encounter. So I have nothing to disclose. This we talked about. So as you know, right, global life expectancy is increasing over the years. So we will be increasingly taking care of definitely an older and an aging population. So issues that are more prevalent in this group definitely will come up more often. So diabetes also is projected to increase in prevalence over the years. In the world right now, so this was 2021, global diabetes prevalence was about 10.5%. And in 2045, it's projected to be 12.2%, which doesn't seem like a big increase, but if you look at the actual numbers, it comes out to a little more than 200 million additional patients. And Sri Lanka specifically also, will be increasing, so 9.8% 2021 diabetes prevalence, and projected to increase to 11.5% in 2045. And as you know, it does increase with age, prevalence of diabetes in both men and women. And there are some changes that go on in the body physiologically that occur with aging as well. So essentially the whole upshot of this is that there is an increase in insulin resistance as people age. So there is increased beta cell senescence, there is reduced beta cell sensitivity, there are changes in people's activities as they age, so less active, changes in eating habits as well occur as people age. Then there's also increased adiposity changes in where fat goes, in particular visceral fat, and sarcopenia becomes more prevalent. So a couple things to really consider in this population. We'll talk about a couple of these things going forward. So the first thing to think about is mild cognitive impairment in this older population. So cognitive dysfunction is actually a pretty common comorbidity in people with diabetes. We don't think about this that often, but it is becoming a little more recognized. More severe stages and progression are often seen in older adults over 65. And then hyperglycemia as well as hypoglycemia are also associated with mild cognitive impairment. So this is important for many reasons, right? So are patients able to administer medications? Are they forgetting medications? Are they overdosing accidentally? Especially important in people on insulin, right? Are they mixing up long-acting and short-acting insulin, which happens not infrequently? So this gets a little into overdosing. Visual impairments can become more of an issue as people age. And this gets into same thing with medications, right? Are they able to inject their insulin? Can they see? So one of the main points of this is to really think about simplifying your regimen in the older population and try to avoid polypharmacy. The next part I'll talk about is hypoglycemia. So older patients are definitely more at risk for having low blood sugars. And some of that is related to changes in cognition, like I mentioned. Worsening renal function occurs, right? So insulin is cleared through the kidneys. And then, changes in eating patterns. People are sometimes skipping more meals. And frailty. All of this can sort of increase risk for hypoglycemia and then also lead to, some issues as well. More issues when people are low. And then, as we know, hypoglycemia can increase the risk of mortality and cardiovascular death. So definitely something that we want to avoid in this group. So if possible, it's preferred to avoid medications that cause hypoglycemia. So cost here is obviously a big issue, but if possible, things like insulin, sulfonylureas, meglitinides are less preferred than other hypoglycemic medications if that's an option. And then the other thing to think about is now to start adjusting the HbA1c target. So this can be challenging because we all have issues with clinical inertia, right? You see a patient in the clinic and the A1C is 6 and you just continue. But as people get older and they have more and more comorbidities, you might consider that 6 might actually be too low and they might be having hypos. And so this is a time really to try to really think about whether your A1C target is appropriate or not. And there are many different societies that have put their finger into what the A1C target should be. ACE guidelines, which is the American Association of Clinical Endocrinologists, probably in some ways is the lowest one. So they say A1C less than 6.5 for everyone who's sort of healthy, and then over 6.5 for everyone else. But the other societies that are out there have sort of a little bit more of a gradation. So the ADA, the American Diabetes Association, in elderly people that are healthy with few comorbidities, you could target an A1C of less than 7.5, which comes out fasting glucose is around 90 to 130, and bedtime glucose around 90 to 150, versus people that are have a couple more comorbidities, a little bit more complex, maybe have mild to moderate cognitive impairment. You might shoot for an A1C less than 8%, which is a fasting sugar you allow up to 150, and then the bedtime glucose can be 100 to 180. And then at the very end, people that are have a lot of comorbidities, very complex, life expectancy isn't that long. You're kind of just trying to keep them out of the hospital. So you're keeping an A1C less than 8.5%. So the fasting glucose can be around 100 to 180, and then less than 200 generally. But each of these societies is sort of have some kind of recommendation about where the A1C target should be. But the general idea is, as people get older, that A1C target should be liberalized to some extent. This is the Endocrine Society guidelines. And one way that we can help our patients avoid some of this hypoglycemia is actually to leverage diabetes technology. So continuous glucose monitors, I think, have been very helpful in this field. There is evidence in people with type 1 that they can definitely decrease hypoglycemia. So this was a nice study that compared people with type 1 diabetes who were using CGM, and they found that their hypoglycemia rate decreased from 5% to 2.6%. People who started with just finger sticks originally and then went to continuous glucose monitoring went from 3.9% to 1.9% of hypoglycemia. So this is, this shown graphically. This is the percent time in range. So these are people that were first on finger sticks and then went to CGM, and it definitely decreased. So it can definitely help our older patients avoid lows. Continuous glucose monitoring also was helpful in type 1 and type 2. So that was type 1, but type 2 as well, helps control the A1C, helps control a little bit hyperglycemia and glucose variability. And then last study was, also another one of these studies, and this was in type 2 on basal insulin. With continuous glucose monitoring, there was improvement in A1C and also time in range. And just some things to think about with using the A1C as your goal. So a lot of the guidelines are obviously use that, but patients with even a high A1C sometimes may have a lot of lows. So just because the A1C is, over 9% doesn't mean that they're having a lot of hypoglycemia. So this is definitely something that should be asked for every patient. So this is, another study that looked at, aging population, and when the A1C was less than 6%, there was a higher relative risk of hypoglycemia, but also when it was over 9% as well. And sometimes when we over-rely on A1Cs, may lead to some over-treatment in older adults because the A1C may not accurately really reflect their glycemic control. Some of that is related to anemia that can occur more often in older patients. So we are sometimes now using the continuous glucose monitor, and we're using time and range for that. So typically, we're shooting for over 70% in healthy younger type 2 patients. In the older population, we're shooting for essentially 50% time in range, less than 50% in this sort of higher range, and less than 1% here for lows. A couple points about some medications for older patients. So metformin, we usually use first. Some things, obviously, renal function declines in older patients, so something to consider with metformin. Patients that now have developed, cirrhosis or other comorbidities that are related to hypoperfusion, also, caution with metformin. GI issues sometimes can affect, appetite, which is a concern in older patients. And then obviously screening for B12 deficiency is important as well. Sulfonylureas, as I mentioned earlier, this is, if you can, less preferred because of the hypoglycemia risk. If this is all that's available, shorter acting sulfonylureas can be better. So things like glipizide. Glyburide, longer acting formulations, try to avoid. And then interestingly, some antimicrobials, so fluoroquinolones, trimsulfa, sulfamethoxyl, trimethoprim can increase the sulfonylurea concentration. So you might consider changing the dose, or you might have to adjust the dose of the sulfonylurea when patients are on those types of antibiotics. I actually do really like DPP-4 inhibitors in the older population. It tends to be, as long as cost is not an issue, it tends to be well tolerated. It's pretty mild. There's no hypoglycemia risk. There's weight neutral. With some of them, there is a heart failure risk, but not all of them have that issue. But if people that are on low dose sulfonylureas, you can sometimes get away with switching them to a DPP-4 inhibitor, which can help avoid hypoglycemia. GLP-1s, you could also think about using in this group. Same thing, doesn't have as much of a hypoglycemia risk, and then also has cardiorenal benefit, which is important in this older population that has a lot of that comorbidity. Cost and access are issues with this. And then the other thing to think about in this older population is, GLP-1s are infamous for causing GI issues and weight loss. And in older patients, you may not necessarily want to drive more weight loss. So that can sometimes be a drawback in this group. SGLT2 inhibitors also can be nice, also have cardiorenal benefit. Couple things to be aware of, elderly patients often already struggle a little bit with drinking enough water and keeping hydrated. And SGLT2s can sometimes worsen that. So that's a consideration. Also, sometimes urinary issues can be more of an issue in the older population, and this can also sometimes compound that as well as SGLT2 inhibitors. And then there's also a risk of UTI and yeast infections with this medication class as well. Pioglitazone, also older medicine. If possible, I do tend to try to avoid this one. It won't cause hypos, which is nice, but it can cause fluid retention. And a lot of older people already are struggling a lot with edema and heart failure and CKD, so already have fluid overload issues. And there is also some data that pioglitazone can increase risk for fracture as well. Insulin, like I said, if it's necessary, it's necessary, but it's less preferred because the hypo risk, the risk for hypoglycemia is fairly high with insulin, obviously. If you really need it, a once daily basal tends to be better, so something like glargine or degludec, so long-acting basal, rather than NPH, which is an intermediate and has a little bit of a peak. So longer-acting, smoother basal insulins tend to have less hypoglycemia. So if you really need to use it, that tends to be preferred. All right, so I'll move into talking about thyroid, so thyroid issues in this older population here. So in people that have pre-existing hypothyroidism, you might see that as they age, the levothyroxine dose might change, and that is somewhat related to the fact that levothyroxine doses are related to the lean body mass, and that adjusts, changes in people as they get older. So the dose may need to be reduced over time. And when you start patients with hypothyroidism on levothyroxine, the dose in older patients you might also consider should be lower. And then the other thing to think about, people end up on all sorts of medications as they get older, so a lot of vitamins and other prescription medications can also affect absorption of levothyroxine. Physiologically, there are some changes that happen in the thyroid axis as people get older. So there is increased clearance of T3 and T4 that happens. There's T3 and T4 clearance decline with age, but production also declines. So everything sort of decreases, but it maintains because both production and clearance are decreased. The one thing that is a little different is that TSH concentrations sometimes we found are higher in older people without any change in free T4. So the idea here is that this is actually more of a shifted set point rather than an increase in the incidence of subclinical hypothyroidism. So it's not that older people have more subclinical hypothyroidism, but maybe that the set point shifts, or that it tends to shift in older people. And this is found regardless of whether they're TPO antibody positive or not. So this is, in numbers, usually the 97th percentile in a younger group, 20 to 39-year-old, that TSH level will be about 3.6. In the 70 to 79-year-old group, that TSH level will be about 5.9, and then in 80 and older, it'll be even higher, so 7.5. And this is pictorial representation of that. So this curve here is sort of like the usual normal distribution, and then if you look at this gold line, this is the older group, so age over 80, and you can see it's sort of shifted to the right. And it's not clear that this is pathologic, so it might actually be protective. So this was a study done in Ashkenazi Jewish population that was looking at centenarians, and it found there was higher, more centenarians essentially had higher TSH levels, so that's this line here. And they compared it both to controls in that same population, but also NHANES. So you can see same thing, in this older group of people, the TSH did tend to be higher. So now this gets into a little bit about, when should you treat this population? Is, any TSH elevation okay? Doesn't need treatment. This was the TRUST study, this trial, which was published a couple years ago now, that looked at older adults over 65 who had essentially subclinical hypothyroidism and randomized them to placebo or to levothyroxine treatment. The baseline TSH was about 6.4. In the treatment group, median dose of levothyroxine was about 50, and the TSH, did go down, compared to the placebo. So after a year, the TSH was 5.4, and the treatment group had gone down to 3.6. And essentially, they found no difference in symptoms. So there was no difference in the hypothyroid symptom score, no difference in the tiredness score. So there is some, despite that trial, there is still some heterogeneity, I would say, in practice. Most people still feel, if the TSH is over 10, it's less likely to be physiologic. So generally, we're treating subclinical hypothyroidism when the TSH is over 10. There is some evidence that when the TSH is that high, there's a higher risk of heart-related issues. So coronary heart disease, heart failure, cardiovascular mortality. In this more intermediate group, between 7 and 10, it's a little less clear. So this was a nice summary of a couple studies that have looked at this. So in more mild groups, so TSH 4.5 to 7, really not much of an increase in cardiovascular events. And TSH over 10, there's some signals in terms of coronary heart disease, heart failure, things like this. And then in subclinical hypothyroidism, maybe some increase in fatal stroke and possibly coronary heart disease events. So the need, in this sort of borderline area, it's a little less clear whether people truly need treatment for this. There's also, not really any intervention studies that if you give levothyroxine to this group that, you'll decrease their risk. And the other factor to sort of think about is avoiding thyrotoxicosis that you have caused yourself to your patient by giving them levothyroxine. because thyrotoxicosis in older patients has its own, issues. So one way you could think about this is, when the TSH is in this mid-range, if they're over 85, think about watching and waiting. A lot of times TSH will normalize when you repeat it. If there's progressive TSH elevation, then, think about treating. In, slightly younger population between 65 and 84, if the TSH is between 7 and 10, essentially. This is a little up to you and your discussion with the patient, right? You can observe versus treat. You might consider treating for patients that already have some cardiovascular issues. And then just a note about subclinical hyperthyroidism, so kind of the opposite end of this spectrum. So low TSH with a normal free T4 tends to become more common in older adults. That's partially because autonomous nodules become more common in this population. And older patients with a low TSH tend to not do as well. So even though the TSH might not be completely suppressed, but it'll be low, so in this range 0.1 to 0.44, those patients do have an increased risk for AFib, coronary heart disease, and hip fracture. So another reason why we like to avoid thyrotoxicosis, whether it's endogenous or if it's iatrogenic. So, we say usually if the age is over 65, those patients should be treated to avoid some of these issues. And then I'll just say, a couple brief words about osteoporosis. This is a reminder to think about osteoporosis in your older patients. We are really bad as a global community. We tend to be not the best about asking people and screening for osteoporosis. So this is from the International Osteoporosis Foundation. Greatly underdiagnosed and undertreated, even in most high-risk patients that have already fractured. Some of that is related to access to bone density machines. Some of that is related to nutrition issues, so not getting enough calcium and vitamin D. Unfortunately, fracture incidence does increase with older age. So, this is as the age increases, fracture, also increases exponentially, let's say. And this is also in osteoporotic specific fractures. So hip fractures, risk factors, vertebral fractures, and women as well as men. As age increases, that fracture risk increases as well. And it can, be as high as, this is 35% of women over 80 will have osteoporosis. A little lower in men, but also still, almost 11%. So, it's very common, very prevalent. And I'll mention in Sri Lanka as well, there was a prevalent study about this. So in women older than 40, more than a quarter of women, 27% of women had osteoporosis. So, it's definitely an issue. It's very common and often sort of gets, I think, forgotten in between other comorbidities that people may have. So I don't have time really to talk much about the management. There's other lectures about this. But the basics, right? Adequate nutrition, physical exercise, and there's many medications out there now that can help improve, bone density. And so, it's not that fractures are just a normal part of aging. There are definitely things that we can do to mitigate that risk. So just a couple key takeaways that if you don't remember anything else, at least remember these. Try to avoid hypoglycemia in older patients. Subclinical hypothyroidism doesn't always need to be treated, and don't forget about screening for and treating osteoporosis. Thank you.
Thank you, Dr. Gossmann, for that interesting presentation. In the interest of time, we'll take questions at the end. The next presentation, you could, come and take a seat. Next presentation is on spectrum of hypercortisolism, autonomous hypercortisolism to overt Cushings. The presentation is by Dr. Ricardo Correa, again from Cleveland Clinic, USA. But unfortunately, he cannot be here in person, so we are going to play a recording of the presentation.
Hi, everybody. Thank you so much to the organizing committee for inviting me to give this presentation. I really want to express my excuses due to personal issues and some health issues at last minute. I will not be able to attend in person, but I really want to give this presentation to make you understand this important topic that is adrenal incidentalomas. The general concepts, a little bit of mild autonomous cortisol secretion in this topic, because it's so important for internal medicine doctor to understand that we are facing increased detection of adrenal incidentalomas and that we need to understand how to work them up. So I hope that you take the key concept of this lecture, and more than happy to answer any question during the section of questions and answers. So thank you so much again. Excuse for everything, and happy to take any questions. So let's start. For this, these are my disclosures. Really, there is no conflict direct with this lecture. I will base all my information on the guidelines and the research that we have been doing on this area. First of all, let's start defining what is adrenal incidentalomas. And this is a finding that occurs in a person that has not been investigated for any oncological process or any metastasis. So it's a finding of more than 1 centimeter lesion in any of the adrenal glands or both. And this happened in patients that present with signs and symptoms of other things. For example, a patient that comes with gastroenteritis to the emergency room and get a CT or an imaging of the abdomen, and in that imaging there is found to have an adrenal nodule. That is if more than 1 centimeter is called adrenal incidentaloma. In some cases, we can consider less than 1 centimeter an adrenal incidentaloma. The first thing when we find this is to determine the etiology of that adrenal incidentaloma. If this is coming from the cortex or the medulla of the adrenal, or this is outside the adrenal. When we determine that it's in the adrenal gland, we have to determine 2 factors that we're going to make a lot of emphasis during this lecture. The first one is this benign or malignant? The second one is this functioning or non-functioning? Why this is very important? Because approximately 5% of all adults in their life, they will find to have an adrenal adenoma or adrenal incidentaloma. So it's very important to determine what is the workup that we will have to do that. And I want to emphasize that this is not in people that we are working for oncological process like staging, or people that have genetic conditions that predispose to have multiple neoplasias. So we are taking that out. The etiology, when we see that is in the adrenal gland, the most common is an adenoma or a bilateral hyperplasia. You can see up to 85% of that is it. And from the adenomas, that is a lipid-rich lesion, the most common is the non-functioning adenomas. But then we have a big group, up to 50%, that can be mild autonomous cortisol secretion, or MACs, from now on. We have some small amount of them that can have primary hyperaldo as an aldosteronoma, and some of them that can have overt Cushing, adrenal Cushing. There's other lesions, and we are going to talk about this one in one slide, the myolipomas, usually occur in patients with congenital adrenal hyperplasia, but then there are other precursors of medulla lesions. And finally, then we have the malignant lesions that will be the pheochromocytomas, paraganglioma syndromes, the adrenocortical carcinomas, and the metastasis. If we look at this systematic review from 16,000 patients published in 2023, we can see that they found approximately 27.5% of all the adrenal incidentalomas were functioning. And from that, the most common, 11.7%, were MACs, followed by primary hyperaldosteronism or aldosteronomas, followed by pheochromocytomas, and followed by overt Cushing, adrenal Cushing. It's very similar data to the one that we are working to publish from the Cleveland Clinic, where we found approximately 7 to 8% of our patients from with adrenal incidentaloma has MACs. But data sometimes it's lacking because of not doing the proper workup of adrenal incidentalomas. If we think about the epidemiology and prevalence of the disease, we know that endocrine organs try to develop nodules with aging. So finding a nodule in an endocrine gland, in this case in the adrenal gland, is very rare in lower ages, so that you can see less than 1% in less than 30 years old. But it gets a little bit more common with older ages, so 10% approximately in more than 80 years old. So it is very critical if we find an adrenal incidentaloma in a younger patient to suspect something is wrong. The male to female ratio is almost 1-to-1. There are a few studies that has compared this, and the side really, there is no prevalence from one side to another, but in one study they show that the right side was a little bit more predominant than the left side. Definitely we have to think that we are talking about numbers not in patients that we are investigating for oncological or staging process. And you can see how much in the staging process, the metastasis is extremely high in the adrenal glands. So a different process. Let's talk about one of the main studies that why we are seeing more adrenal incidentalomas nowadays. And this is because in the last 3 years, the amount of abdominal imaging has increased exponentially. This study from the Mayo Clinic showed that in the last 3 years, that imaging has increased, and with that, there has been an increase on the diagnosis of adrenal incidentalomas. Mainly, the majority of them, 90% of them benign, being adenomas, and some of the adenomas producing, in this study, they found up to 37% being max, and the rest being non-producing tumors. So it's very, very important that whenever we have an adrenal adenoma that was detected in an imaging, in an abdominal or chest imaging, then we have to work them up. And this is the thinking process that we have to do whenever we see an adrenal incidentaloma. The first thing is to determine if this is in the adrenal or extra-adrenal, as we mentioned at the beginning. Sometimes some lesions can be extra-adrenals, but it can be read as adrenal. Always is good to discuss this case with radiologists, or if you have experience, then look at the imaging yourself. We have several cases where splenial was confused by an adrenal adenoma. If we determine that this is definitely in the adrenal gland, now the next step that we're going to talk about is this benign or malignant? And that's a question that we will answer with images. And parallel to that, we have to ask another question, if this lesion is producing something or not. And this we will answer with biochemistry of lab or lab work. Let's first start with the question about this is benign or malignant. We will answer this question with images, as I mentioned, and these are the 3 radiological images that we can use. The first 2, the anatomical imagings, are the most sensitive and specific, CTs and MRIs. The third one, the functional imaging, nuclear medicine studies are in process of getting better, but really we don't use it so much to determine this is malignant or benign. It's more used when it's staging, when we want to see the spread and all of other things. But the first 2 anatomical imagings are very, very sensitive and accurate to determine if this is malignant or benign. Let's start with the most common that we use, and it's the CT. So in this CT, what we will assess is the amount of lipid that is in that nodule. And how do we assess the amount of lipid? With the Hounsfield unit. Hounsfield units compare the amount of fat that is in the nodule compared with the liver. And we know when the Hounsfield unit are low or less than 10 Hounsfield unit, the amount of fat is very high. So most likely this is an adenoma, and this will be a benign lesion. When the amount of fat is low, meaning high Hounsfield unit, more than 20, the probability that this is malignancy increase. So the most important thing that I'm going to mention when you look at an CT of the adrenal glands is to look to the unenhanced CT and determine the Hounsfield unit or the amount of fat that is in that nodule. If the amount of fat is high, this means that it's most likely an adenoma. If the amount of fat is low, there's high risk that this is a malignancy. And in malignancy, it's the capacity of metastasize of the nodule in the adrenal gland. So malignancies are pheochromocytomas, are adrenocortical carcinomas, and metastases. Malignancy doesn't, a benign lesion doesn't mean that you are not producing something and can be a malignant consequence. But it means more that it's the capacity of metastasize in a benign lesion is low. Also, the size we will take into consideration, but when we compare size and density, you will see that density is more important in determining the malignancy of a lesion. So where the cutoff of 10 came, and very fast, we are going to go, this systematic review analyzed 6 studies, and when they used the cutoff of more than 10 Hounsfield unit, they found that 100% of the lesions were malignant. Of course, they were virtual no malignant lesions less than 10 Hounsfield unit. There were some cases and have been some report of pheochromocytomas with less than 10 Hounsfield unit, but in medicine, not everything is 0 or 100%. So the cutoff of 10 works very well as a sensitive cutoff, but the specificity is 58%. So meaning that there are benign lesions that can be more than 10 Hounsfield unit. So then that is why they move the cutoff and they say, let's see if we want to rule out the benign lesions if we put more than 20. And when they did this, they found that the sensitivity was 97%. So really there was a low amount of benign lesions more than 20, the cutoff of 20 Hounsfield unit. But between 10 and 20, there were some metastasis lesions. So now we have a cutoff of less than 10, very sure that this is a benign lesion, more than 20, very concerned that this is a malignant lesion, and then we call the indeterminate lesions between 10 and 20 Hounsfield unit. Again, on-enhanced CT, this is not, we're not talking about contrast, we're talking about an on-enhanced CT is the one that provide us the most sensitive and specific information. Here I just want to show you one left adrenal incidentaloma that was 2 Hounsfield unit, characterized of an adenoma. We can also utilize the condition or the washout technique. This is usually used when we have an indeterminate lesion, that lesion that is between 10 and 20 Hounsfield unit. Then we can use the washout, and it's the amount or how fast that lesion wash out the contrast. Benign lesions will wash out very fast. Malignant lesions will be less. So in the past, we use a cutoff of absolute washout of more than 60% and relative washout of more than 40% to determine that the lesion was benign. Really, in the latest studies, it has shown that a cutoff of a relative washout of more than 58% only provides specificity of 15%. So it's not a very accurate technique. That's why it's not good to use it in every single adrenal incidentalomas. I will prefer that you use it only in those indeterminate lesions. So when the on-enhanced CT shows a Hounsfield unit between 10 and 20. Because the on-enhanced CT will provide you more information of benign or malignancy. Here I want to show you the progression of an adrenal adenoma. So as you can see, it started being the first year, some small lesion. The second year you can see, the first time or the 1 year after, you can see that there's really no growth, same characteristic in the right side, adrenal incidentaloma. 2 years after, it's same characteristic. 3 years after, same characteristic of minimal growth. So an adenoma really is a lesion that is fatty, the tissue, that will really grow very slow. I'm not talking about function. Function we are going to talk about later. In contrast, an adrenal carcinoma will present different. You can see an increase of more than 20% in diameter or as per the Korean Endocrine Society, more than 1 centimeter per year. Here you can see 1 year after there is growth, and look 2 years after there is growth and even necrosis inside. So that's why it's very important to catch up an adrenal carcinoma or a malignancy earlier, even though it's not producing anything at the beginning. They can be sometimes silent, but the Hound's feel unit high, and that creates a concern, because then when we catch it later, it's more difficult and there are more complications. The other technique that we can use is an adrenal MRI. Is a different technique. What we are looking is a chemical shift in between comparing the phase and the opposition phase. So when the shift, the chemical shift is high or more than 16.5%, this means that it's a fatty rich tissue and it's an adenoma. So we will have to see the chemical shift between T1 and T2. Here is how you will see it in an MRI. As you can see, the one in the right side, or sorry, in the left side is in phase, and in the right side is in the opposition phase. And you can see that the color changed from a little bit gray to black. That is a 72% chemical shift or loss of signal, and that means that it is a fatty rich tissue. If we decide what is better, CT or MRI, really there is no significant difference, but we know that CTs are cheaper and they provide as good information as MRI. Of course, there will be some cases where MRI will be indicated for people that have some nephropathies in kids, pregnancy, and adolescents. They are indicated MRIs. But if your patient can have a CT, there is no contraindication for a CT, the best option will be to have a CT. Nuclear medicine studies, there's a lot of new research on this area. I just want to emphasize that really it's not a study that we actually use to determine malignancy or benign lesions, because there are some false positives like pheochromocytomas, small pheochromocytomas, inflammatory lesions, and infectious disease, and possible false negative, some metastasis will not uptake. So there is some concerns that definitely in the new techniques that we have in nuclear medicine are more sensitive, and probably in the future we will change this. But for now, using anatomical imaging are as good as we can get. If we think about the tumor size, we know that really when we get a bigger size, there is more probability of having a malignancy. And if we can think about the cutoff of 6 centimeters, almost half and half are benign and malignant. So very high risk of malignancy after 6 centimeters. 4 centimeters is whenever the malignancies start appearing more. 6 centimeters, almost we get half and half. And in this study from the Mayo Clinic, we can see that really all malignancies were more than 4 centimeters, and benign lesions were less than 4 centimeters. So between 4 and 6 is indeterminate. More than 6 is very highly that is malignancy. Less than 4, very highly that is benign. Of course, there are lesions, and in this slide, I want to talk about it. If we say what is more important, size or density, we talk about the density using the Hounsfield unit. And when you compare, you can see that at the end of the day, density gives us more information than size. So even though some tumors are small, if the density is high, they are concerning for malignancy. Adrenal biopsy, just a few seconds on this, really are not indicated unless there is a history of extra-adrenal malignancy. And every time that we are going to do an adrenal biopsy, if we are concerned on something, we have to do a workup to see if there is no active hormone producing. What are the causes of the adrenal lesions? They can be non-functioning and functioning. We already talked about benign or malignant, but non-functioning and functioning sometimes interlaps. For example, an adenoma can be a fatty tissue that is non-functioning, but also can be producing things like the Overt Cushing or aldosteronomas or MACs. an adrenal carcinoma or pheochromocytoma can be silent and they can start being non-functioning, but also they can be functioning. So we have to take into concern both things, the malignancy, but also the biochemistry that will tell us is this functioning or non-functioning. Myolipomas is a benign lesion, fatty lipid-rich lesion, sometimes that can be very big, and in these cases, even the size in those cases is high, the density is low, and they are benign lesions. Sometimes can be calcified, and if we do nuclear medicine study, they are PET negative. Just here, I want to mention adenoma, that is a fatty lipid or fatty rich lesion that can cause overproduction of cortisol, and this is the adrenal Cushing or overt hypercortisolism due to adrenal lesion. Is relatively rare, as we talk about, between 1 to 4%. The peak incidence is 2 cases per million. And it's subdivided into adrenocortical tumors, so one nodule, or it can be bilateral micronodular hyperplasia or bilateral macronodular hyperplasia. This is PPNAD or PMAH. So there are some somatic and germline mutation that has been discovered in some of this bilateral macro or micronodular hyperplasia, and then we can discuss more of those during the questions and answer. Malignant lesions, carcinomas, adrenocortical carcinomas also are rare. They usually are large in size. Their borders are irregular. They can have calcification. They uptake for the PET or nuclear medicine studies. And here you can see some lesions that are huge in size with some necrosis on it. Other malignant lesion, pheochromocytomas, as we know, are catecholamine-secreting tumors. Sometimes they can be silent if they are small. Other times the presentation are with symptoms. The most common is that the Hounsfield unit are high, more than 20 usually. There are some that can be more than 10, but really the concerning is more than 20. The shift, chemical shift is low when we use MRI, can have necrosis or hemorrhage, and majority of them uptake for nuclear medicine studies. And the last malignant lesion, the adrenal metastasis, you can see here that they uptake a lot in when we use nuclear medicine studies. And the important thing is that the density is very high. In this case, we say a 43 Hounsfield unit. This was a patient that had history of cancer. So in a patient that you are staging, very concerning if you find a high density lesion that is in a metastasis and can be bilateral. So just again, going through the process, first, always the clinical history of the patient is important because we have to determine if the patient has some comorbidities like this metabolism, hypertension, hyperlipidemia, obesity, osteoporosis, osteopenia. That's very important because some of the phenotypical characteristic of these nodules that produce something like in MAX will cause some of this metabolism. The second part is what we did. We went through the imaging studies and determined if this is benign or malignant. Now we're going to go to the biochemical phenotypes to see if there is producing or not producing. Before we move to the biochemical phenotype, I want just to mention certain characteristics of benign lesions where it says adenoma compared with malignant lesions where it says pheochromocytomas, HCC, and metastasis. We can see that the size is smaller in benign lesions, that the density is low in benign lesions, that the washout is high in benign lesion compared to malignant, that the chemical shift is higher in benign lesions, that there is really no necrosis or hemorrhage in benign lesions, and the growth is very small as we saw in the adenoma picture compared with the malignancy lesion, that the growth is faster and faster in adrenocortical carcinomas. Biochemical assessment, as we were talking about. Really, there is 3 things that we should do. The most important one is the 1 milligram dexamethasone suppression test. you provide 1 milligram to the patient before going to sleep, and then you draw the blood and the dexamethasone levels, or you can draw ACTH after you in the morning. You have to take into account that dexamethasone can stay in the fat tissue. So if the patient have overweight or obesity, probably 1 milligram is not just enough. We have to increase it to 2 milligrams or 8 milligrams. This is for every patient that you see with an adrenal incidentaloma. All of them should have a 1 milligram. And this is where I was mentioning that we have to standardize. So everybody that see an adrenal incidentaloma should work this, at least this first part is given and the test of 1 milligram dexamethasone suppression test. If the patient have history or is taking blood pressure medication and have hypertension, we also should work every patient with hypertension in the new guidelines recommended that they work up with renin and aldo and the ratio. And finally, if you find that that lesion is high Hounsfield unit, meaning more than 20 or indeterminate 10 to 20, you should work the patients with metanephrines, urine or serum. I know that urine are a little bit more accurate, but are a little bit more intensive for the patients. So what I start doing is working with serum, and if it comes up normal, I go with the urine. So just in summary, the 3 workup, the most important for every single patient is the 1 milligram dexamethasone suppression test. If the patient have hypertension, renin-aldosterone ratio, and if the Hounsfield units are elevated, then we do also metanephrines. This is the algorithm from the guideline published in 2023 that are the latest guideline on adrenal incidental-talomas. So we talk a little bit about this, and we are going to go a little bit more. You have to assess in parallel benign or malignancy. So we can use a CT if we know that less than 10 Hounsfield unit, benign. We can do MRIs if there is chemical shift, benign. We can do an FDG PET, and if there is no absorption, most likely benign. And the cutoff of relative washout of more than 58%. So if the lesion is benign, as per imaging characteristics, in parallel also we are doing the functional test. And in the functional test, we did the 1 milligram dexamethasone suppression test. It came suppressed or less than 1.8. We did, we don't have to do because it was less than healthy unit plasma and urine metanephrines. Let's say that the patient have hypertension and the renin and aldo comes normal. Then now we have a lesion that is benign, that is non-functioning. Then we can determine that there is no further investigation. So we don't have to follow this patient every year for 5 years like we were doing in the past. This patient with a benign lesion characteristic by imaging and a non-functioning producing in our first test determine that the patient is not needed for their workup. There are other cases. Let's see when the mass is not strictly benign. It's an indeterminate mass, and we will go through the algorithm of that. Or when there is some production, and meaning there is a production of mild cortisol between 1.95 and its max. Or if there is overproduction, there is an aldosteronoma, there is overt Cushing, there is a malignant lesion that we have to remove. So let's go with the indeterminate lesions. So we talk about the benigns already, but what happens if the lesion is between 11 and 20 Hounsfield unit and the tumor is less than 4 centimeters? In those cases, you can do 2 things. One, an additional imaging, in this case, an MRI, or the other is you can follow with the same imaging in 12 months. The other cases are if the lesion is between 11 and 20 Hounsfield unit and the tumor is more than 4 centimeters, or the lesion is more than 20 Hounsfield unit and the tumor is less than 4 centimeters, or there is heterogeneous lesion with the tumor less than 4 centimeters. On all those cases, the recommendation is to have a multidisciplinary meeting and proceed with the other imaging, in this case MRI, and a discussion in the multidisciplinary team. As per the guideline, multidisciplinary team include an endocrinologist, an endocrine surgeon, and a radiologist. The last cases are the cases where the Hounsfield unit is more than 20 and are big size, more than 4 centimeters, and more than an heterogeneous and more than 4 centimeters. These cases, most likely are going to surgery, and the recommendation also discuss this in the multidisciplinary team. So the last two are the cases where most likely surgery is the most appropriate thing, but if the patient wants to do more investigation, we can do other imaging to confirm what we find, and this has to be discussed in a multidisciplinary team. So now let's go to the other algorithm, that is a benign adrenal mass that can produce some kind of excess of cortisol, and this is MAX. So we are going to do the 1 milligram dexamethasone suppression test, and if it comes less than 1.8 or 50 nanomoles per liter, then we rule out and we know that this is not a MAX. But if it comes more than 1.5, or sorry, more than 1.8 or more than 50 nanomoles per liter, we have to see in our clinical history if the patient has signs or symptoms of overt Cushing. If the patient do not have signs and symptoms of overt Cushing, then we can consider that this patient has mild autonomous cortisol secretion or MAX, and then we will have to treat the patient. And we will talk a little bit more of MAX in the next upcoming slides. And finally, we are going to go through the route of patients that has an overt production or has malignancy. So these patients will have to go to surgery. Remember, always discussing the multidisciplinary team, and then this is some of the recommendations that Dr. Berber will talk about when to do open or laparoscopic adrenalectomy. A little bit of bilateral adrenal incidentalomas. It's occur a little bit on 15%, but it can occur to 29% of the patients. They are peak between 5 and the 50 and 60 years old. They can be associated with some somatic and germline mutations, meaning RMC5, one of the most common, and is associated with hypertension. And the best approach always is treat each adenoma independently, because as you can see in this slide, you can see that it can be 2 benign lesions, 2 malignant lesions, 1 benign, 1 malignant, 1 hyperplasia, 1 nodule, or it can be 2 nodules on the one side and 2 of them benign. So there's multiple combinations, so each one should be treated independently, as we are talking about in the past when we address 1 adrenal nodule. Primary macronodal hyperplasia, I just want to mention that this is in the past called IMA. It's they are large nodules that occur in bilateral disease, are very related to genetic mutation, the most common RMC5, and they can go from silent to overproduction or cross-secretion of cortisol and aldosterone. This is one of our cases published. You can see here, this is a patient, a 75-year-old patient with a bilateral primary macronodal adrenal hyperplasia. In each adrenal, she had approximately 20 nodules, and each nodule had a germline mutation in RMC5 and a different mutation, a somatic mutation. So it was really interesting, and it's a unique disease. PPNAD is a micronodular, so we cannot detect it on the CT. It's associated with cardiac complex, but can be detected alone, and really the treatment is bilateral adrenalectomy. With extra-adrenal malignancy, always to have to consider life expectancy if we are going to proceed to do something, and definitely in those cases, doing a nuclear medicine study for staging is important. The special situation is as I mentioned at the beginning, any younger person or pregnant woman that we detected an adrenal adenoma should raise some concerns, but also patients that are in poor health or frailty. On those cases, we also have to consider how aggressive we want to be. And this is just to show you the progression of the guidelines since 2003, the first one that the NIH produced, where they say that you have to repeat CTs and imaging, to the 2023, where you say that if this lesion is benign, and non-functioning, you didn't really have to work them up anymore.
I don't know if you have any questions on this topic. I think you can ask at the end of the symposium, and our panelists will be happy to answer. Our next speaker is Dr. Udul Hewage. Dr. Udul Hewage is a senior consultant physician and a senior lecturer, Flinders University, Australia. Over to you, sir.
Thank you, Uditha, for introduction. At the outset, let me thank the president and the organizing committee of the Ceylon College of Physicians for inviting me to be part of this Congress. It is indeed great pleasure and privilege to be here. This is just to show that where I live and practice, people who do not know much about Adelaide. Adelaide is the capital city of South Australia. Sorry, how do I move this? Where is the spacebar? This one? Oh, this one. Okay. Yeah. This is a bird's eye view of the Adelaide city, showing some iconic landmarks. You can see pictures Adelaide Oval, and then the gorgeous Torrens River, which flows through the heart of the city. And also on the background, you can see Adelaide Hill, where a world-famous wine is made. As you know, we all like to enjoy occasionally a glass of wine, but of course, if you indulge excessively, it can cause other problems, including more visit to the toilet that is due to osmotic diuresis causing polyuria. So that gives me a nice segue to my talk today on approach to polyuria. This is what I'm going to talk about over the course of next 20 to 25 minutes. I will recap the basic physiology of water homeostasis, followed by definition and initial assessment, then stepwise diagnostic approach, treatment, and a couple of summary slides. Now, the main hormone that controls the water hemostasis is the antidiuretic hormone, or arginine vasopressin. It is synthesized in the hypothalamus and stored in the posterior pituitary gland. There are a couple of important triggers for ADH release. One is that a plasma volume, and two is the plasma osmolarity. If plasma osmolarity goes up, or volume depletion, that leads to increased secretion of antidiuretic hormone or vasopressin. ADH act on the kidney, act on the collecting duct tubular level. The cells which have receptors for ADH action is depicted in this cartoon. It's a bit of a complex cartoon. You don't have to remember everything, just to highlight a couple of things. ADH latches onto the receptor on the cell membrane called V2 receptor. It triggers a cascade of chemical reaction, which eventually lead to opening up of water channel called aquaporin 2. Now, osmotic gradients from lumen towards the bloodstream play a significant role in water movement from lumen to the bloodstream. Now, the plasma sodium and urea level is the two main drivers that maintain this osmotic gradient. Polyuria is not an uncommon clinical problem. It's about, if you look at its prevalence in hospital setting, it varies between 30 to 40, depending on what population that you study. There are a good proportion of patients with the symptoms present at the community level to the GPs and other clinicians. Hence, my talk is pitched at that level to cover the community clinician as well as clinicians working at the hospital. Now, majority of the patients who have the symptoms of polyuria, in fact, does not have true polyuria. Most of them have what's called polyuria mimics. What are they? Increased frequency, nocturia. Those are due to conditions such as benign hyperplasia of the prostate, urinary tract infection, or irritable bladder, or due to diuretics. Now, if you want to tease out this polyuria mimic from true polyuria, you have to collect a 24-hour urine to make sure that the urine volume exceed the magical figure of 3 liters, or more precise, 40 mils per kg. So if your patient passes more than 3 liters, then you are dealing with patients with true polyuria. So once you establish that your patient has true polyuria, the next step would be to categorize which category of the polyuria in terms of etiology. There are 2 broader categories: osmotic or solute diuresis causing polyuria, or water diuresis causing polyuria. The solute diuresis or osmotic diuresis is due to presence of osmotically active particles in the urine, which is responsible for retaining water inside the lumen, and that volume of water is necessary to excrete the osmotically active particles. So the water excretion in osmotic diuresis is appropriate, whereas water diuresis, the water excretion is inappropriate. Hence, if you compare the urine osmolality, patients with water diuresis have much lower urine osmolality compared to osmotic diuresis. Now, this shows you some of the common osmotically active substances which causes osmotic diuresis. Most common being glucoseuria. In patients with high blood glucose level, when it exceeds the renal threshold, can cause polyuria. Or if the patient, you started the patient on SGLT2 inhibitors, which inhibit glucose absorption, it can cause temporary polyuria at the initial stage. If the blood sugar level is very high, it spontaneously resolves once the sugar comes down. Polyuria can occur in patients who are improving with their severe acute kidney injury. In this instance, urea being the osmotically active substance. Or if you give copious amount of intravenous saline, that happens more often than not in surgical ward during post-operative period. It can cause polyuria due to osmotic diuresis, the offending agent being sodium chloride. And of course, you know, mannitol is an osmotic diuretic, which can cause polyuria as ethanol. Now, there are, going into water diuresis, there are 3 main causes of polyuria due to water diuresis. The primary polydipsia, where the patient has voracious thirst and drink gallons of water, resulting in passing very dilute urine. Majority of these patients do have a history of psychiatric illnesses, and they may be on certain antipsychotic medications such as phenothiazide, which may play a role in polyuria. Or it could be due to rarely hypothalamic lesions can cause increased thirst as well. Then comes arginine vasopressin deficiency and arginine vasopressin resistance. These are formerly called central diabetes insipidus and nephrogenic diabetes insipidus, respectively. However, this terminology is now changed to AVP deficiency and resistance due to confusion of diabetes insipidus with diabetes mellitus. We move into a central diabetes insipidus or vasopressin deficiency. It could be complete or partial. In partial AVP deficiency, where ADH secretion occurs, and it occurs to the triggers that we discussed, but of course it is suboptimal or submaximal. The causes which causes central diabetes insipidus include head trauma. If someone gives a history of trauma to the head and develop polyuria, it's most likely due to the head trauma. Then, of course, large pituitary tumor, especially following transphenodal resection of pituitary tumor, can lead to temporary polyuria, temporary ADH deficiency leading to polyuria, and very easily treated with synthetic ADH such as desmopressin. Or it could be due to infiltrative disorders like sarcoidosis. Now, some of the monoclonal antibody drugs can also cause ADH deficiency leading to polyuria. Then the majority of the patients with the basic investigations or specific investigations, you may not find an underlying cause that is idiopathic. In fact, post-mortem studies have shown that majority of these idiopathic cases due to presence of autoantibodies against the hypothalamic cells that produce ADH. So majority of these patients who were previously categorized as idiopathic could have autoimmune etiology. Now, coming on to arginine vasopressin resistance or nephrogenic diabetes insipidus, similar to ADH deficiency, it could be complete resistance or severe degree of resistance or partial resistance. The milder form exists in elderly people and those who have underlying kidney disease as well. And most elderly people, even though it causes frequency, perhaps it's not severe enough to cause disabling symptoms interfering with their day-to-day life. There are two main causes of ADH resistance in clinical practice that you come across. Lithium is one of the main culprits, especially chronic lithium use, which causes dysfunction of the aquaporin 2 receptors, resulting in resistance to ADH. Or significant, either moderate or severe hypercalcemia, usually over 3 millimoles per liter, can cause resistance to ADH, resulting in polyuria. Now, this is due to deposition of calcium in the principal cells and the renal interstitium. It interferes with the osmotic gradient as well as interfere with the function of the ADH at the receptor level. Now, how do we evaluate a patient who comes to you with a history of polyuria? I think in clinical medicine, most important screening test is a thorough, a comprehensive history. You cannot substitute history by doing various investigations. So if the onset is gradual, it's more likely that you are dealing with either primary polydipsia or renal resistant to ADH causing polyuria. Or if it is abrupt, it points towards a pituitary or hypothalamic cause resulting in ADH deficiency. If your patient has a strong family history of polyuria, which is a very rare condition, of course, that triggers that you may be dealing with a genetic cause at the receptor level. Now, nocturia is one of the earliest symptoms in the history. The result, this is due to, as you know, when we don't drink fluid during night when we sleep, it triggers excessive or increased secretion of ADH, which causes water absorption. But that is disrupted in patients with both central and nephrogenic diabetes insipidus, resulting in nocturia. The basic investigation that you could perform in the community level, check a blood glucose level. If it is high, that basically clinches the diagnosis straight away. Then you do serum sodium and calcium level, urine and plasma osmolality, and if you know urine osmolality and urine volume, then you can easily calculate daily osmolar output. That's helpful in differentiating between ADH resistant and ADH deficiency. If your patient has a low concentration of sodium and low urine osmolality, it points towards a possible primary polydipsia. If your patient, the serum sodium level is raised along with urine osmolality less than the plasma osmolality, you may be dealing with arginine vasopressin disorders. In primary polydipsia, as I mentioned earlier, urine osmolality is significantly lower and is usually less than 1/2 of the plasma osmolality. If the plasma sodium level is normal and urine osmolality is 600, when urine osmolality over 600 or so, that effectively rules out any arginine vasopressin disorder, whether it's central or nephrogenic. It's most likely you are dealing with osmotic diuresis. When you calculate total daily osmolar output, if it is, say, very high, say, for example, over 1,000 milliosmol per kg, then, of course, that basically clinches the diagnosis of osmotic diuresis. Now, once you rule out osmotic diuresis, you are left with water diuresis. We discussed 3 main causes of water diuresis. To tease out between these 3, we have to perhaps do the next level of investigations. When it comes to that stage, that is the time that you may refer this patient to your specialist endocrine clinic or specialist medical clinic in the hospital. So the test of choice at the moment is water deprivation test. This is to achieve serum sodium over 145 and plasma osmolality 295 milliosmol per kg. The rationale of these magic figures is that if you achieve this sodium and plasma osmolality, plasma sodium and plasma osmolality, that indicate that you have reached the maximum renal concentrating ability. If you further increase ADH level by giving exogenous desmopressin, we would not expect a rise in urine osmolality. So once you have done the water deprivation test, usually it's overnight, about 10 to 12 hours, you should be able to achieve this sodium and plasma osmolality target. If you cannot achieve that, then you may combine with infusion of hypertonic saline very judiciously while monitoring sodium and osmolality level. Once you achieve this level, then there are 2 ways of proceeding the test further. Either you give desmopressin. Desmopressin is an ADH, synthetic ADH analog. You can give intranasally, and you measure the plasma, we measure the urine osmolality before and after desmopressin and see whether there is a significant response. Now, or you can combine it if you have a good lab which can perform copeptine or vasopressin level. But of course, unfortunately, there are only few labs that can perform this test with accuracy, especially vasopressin test is not very accurate due to a lot of reasons, while copeptine test is not that difficult. I will talk about copeptine a bit more in the next slide or two. Now, response to desmopressin without prior water restriction, we may have to do in certain categories of patients. So water deprivation cannot be done each and every patient with polyuria. There are patients who are not suitable candidate for this test due to the fact that there is a risk of severe hyponatremia and severe dehydration. Say, for example, if someone is passing liters and liters of urine, if you deprive them any fluid or water, they can very easily go into severe dehydration and severe hyponatremia. So those patients, we may have to modify the test or do the alternative test to clinch the diagnosis. Now, once you've done the water deprivation test, how do we interpret the results? If the urine osmolality is, say, for example, over 500 milliosmol per kg, and no response to desmopressin, then that point toward primary polydipsia. If the urine osmolality is low, relatively low, it could be either due to ADH deficiency or resistance. If urine osmolality after desmopressin increases, then you are dealing with vasopressin deficiency. If there is no further rise, it is nephrogenic diabetes insipidus or vasopressin resistance at the kidney level. All right, so as I mentioned, we may have to avoid this test in certain categories of patients who are at greater risk of severe dehydration and hyponatremia. So those patients having access to especially plasma copeptine is quite handy. So plasma copeptine is a glycoprotein moiety of the precursors of ADH. It secretes in equimolar volume to vasopressin, and it has a stable half-life, and it's very stable when you check the levels. So copeptine is an excellent surrogate marker of vasopressin level. But unfortunately, only very few labs have the capability of doing this test. If a single baseline copeptine level, even without water deprivation, is significantly high, that effectively confirm arginine vasopressin resistance and rule out primary polydipsia and deficient ADH deficiency. So low plasma copeptine level after water deprivation or hypertonic saline clinch the diagnosis of AVP deficiency. If it is high, it points toward polydipsia. If your patient cannot undergo water deprivation at all, then the alternative would be to infuse arginine. As you know, arginine is a substance that stimulates pituitary gland to release more ADH. If there is no significant rise in copeptine level following arginine infusion, that strongly point towards a diagnosis of central diabetes insipidus or ADH deficiency. So after desmopressin, if urine osmolality doubles, usually over 300, it points toward complete vasopressin deficiency. If there is no or minimal rise in urine osmolality, it points toward arginine vasopressin resistance. When it comes to, this is not that difficult to differentiate complete ADH deficiency from complete ADH resistance from primary polydipsia. But when it comes to partial deficiency or partial resistance, that is where problem arises in interpretation of water deprivation test. As you know, the specificity of water deprivation test is not that great. It's about 70%. But if you combine it with plasma copeptide, you can significantly increase its sensitivity and specificity. In partial vasopressin deficiency, especially chronic partial deficiency, it can cause downregulation of V2 receptors. Hence, when you deprive these patients from water, they can maximally concentrate urine and no further rise after desmopressin. So that makes it difficult to differentiate primary polydipsia from vasopressin deficiency. So if the water deprivation test is non-diagnostic, we can initiate therapeutic trial of desmopressin. You give about 3 to 4 days of desmopressin and see the response. If the patient has partial deficiency, they will have symptomatic relief with normalization of urine output and electrolytes. If there is primary polydipsia, there is no symptomatic relief, but of course there is a high chance of developing hyponatremia. So I think a couple of more slides, if that's okay. The treatment based on the etiology. If it is osmotic diuresis, you identify the culprit agent and stop it. Primary polydipsia, you deal with the underlying psychiatric problem. The partial deficiency usually respond very well to low salt, low normal protein diet. You may use hydrochlorothiazide, and if the patient is still not responding, you can start desmopressin. The goal of therapy is try to reduce the symptoms. AVP resistance, correct the underlying disorder. If you can identify a medication that could cause AVP resistance, you stop that. You treat hypercalcemia. When the patient becomes normocalcemic, it alleviates the symptoms. Lithium, of course, chronic lithium-induced nephrogenic diabetes insipidus is irreversible, but if you can detect them early, then it can be treated, especially with drugs such as amiloride, which is specifically effective against lithium-induced nephrogenic diabetes insipidus. Of course, some of these patients do respond to desmopressin if the resistance is partial. All right, in summary, so differentiate true polyuria from polyuria mimics. Then decide whether it is solute diuresis or water diuresis. If it is water diuresis, tease out between these three conditions. And as I mentioned, history is the most important thing. And treatment depends on underlying cause. If it is deficiency, desmopressin, resistance, hydrochlorothiazide, other diuretics as well. Thank you for your attention.
Thank you very much, Dr. Udul Hewage. Let me invite you to take a seat on stage. And in the interest of time, we can take 1 or 2 questions from the audience. Dr. Sachith, can I ask you a question? Now, we know that in our country, we do not have ready access to bone mineral density measurements with DEXA. And then in the context of the first talk about endocrine problems in the elderly, so what are the other ways of diagnosing or predicting fracture risk in the elderly, especially in countries like ours?
Yes, so DEXA availability is very limited in the country. Even in the private sector, only few hospitals have DEXA. One other thing which you can use is we have this FRAX model, and we have the Sri Lankan specific data for the FRAX model. And you can use actually the FRAX without the DEXA input as well, with DEXA or without DEXA. And there have been some studies carried out in Sri Lanka which have shown that even if you do without the DEXA input and if you calculate the FRAX, still you get a fairly accurate level of good values. So like in about 80% sensitivity and 80% specificity. So I think that's something which we can use in our patients to assess the fracture risk, because osteoporosis is a common thing, and we know hip fractures have a very high mortality rate. And the other thing is sometimes these patients some patients undergo these back x-rays, and if you see vertebral fractures, probably without any significant trauma, and if you can consider these fragile fractures, so those patients are very likely to have osteoporosis. So you can actually start treatment in those patients, even without DEXA, and most of the time we need DEXA actually to compare the response to the treatment. So even these patients we can start, and the FRAX model, I would say, would give us a good guide to assess the fracture risk and treat. And while you do that, when you get the opportunity, you can also do a DEXA, which will be useful in the follow-up of these patients.
There's one question.
As you talk about the FRAX score, I just want to ask another question on it. FRAX score just apply 40 to 90, isn't it? Because in these extreme ages, when you're calculating the osteoporosis risk, is there any validated tool for Sri Lanka? Because I'm practicing in UK. We use a Q fracture score for above 90. Is there anything that we use in Sri Lankan setting for extreme ages?
Yeah, unfortunately, you're right. So extreme ages, we don't have any valid tool to use. But up to about 90, we can use a FRAX score. Above that, you have to go with the clinical context, and based on their fracture risk, you have to decide on treatment.
I think in the interest of time, we should conclude this symposium, and let us all thank the speakers in the usual manner. Thank you.